In this disease, there is abnormal accumulation of fluid within the pleural space. So this is called as pleural effusion. Now let us see how to approach to pleural effusion. Whenever they give you any pleural fluid analysis, how to come to a conclusion regarding the diagnosis. Previously we have seen the clinical findings in pleural effusion. Is it a pulling lesion or a pushing lesion? It is generally a pushing lesion. And on the chest X-ray you find whitish density with meniscoid fluid level. And if you percuss, there is a classical stony dull note heard. Then based on Light's criteria, we generally classify pleural effusion into two entities. So we have transudative pleural effusion and other is exudative pleural effusion. And how is it classified? Based on Light's criteria. According to Light's criteria, if pleural effusion protein by serum protein, pleural effusion protein by serum protein less than 0.5, pleural effusion LDH by serum LDH less than 0.6. If the protein ratio is less, LDH ratio is less, this is transudative pleural effusion. Now to call it as exudative pleural effusion, any one of the following: either protein ratio is more than 0.5 or LDH ratio is more than 0.6. So whenever there is exudative pleural effusion, it means there is some damage to pleural membrane. So from the systemic circulation, proteins and LDH can leak into pleural space, whereas transudative is generally due to a systemic cause. Generally it can be either due to increased hydrostatic pressure or reduced oncotic pressure. Now whenever it is transudate, life is very easy because majority are related to systems. So the first system that you need to keep in your mind responsible for transudative pleural effusion is cardiac failure. So right now cardiac failure is considered as most common cause of pleural effusion overall. Then what is the mechanism of pleural effusion in cardiac failure? So for fluid to accumulate anywhere, either there is increased hydrostatic pressure or decreased oncotic pressure. So this is a situation of increased hydrostatic pressure. The next system responsible is your kidney, and the disorder is nephrotic syndrome. So how is nephrotic syndrome responsible? In nephrotic syndrome, there is massive proteinuria. So the reason for pleural effusion here is reduced oncotic pressure. Then third system is your liver. If liver disease is responsible for pleural effusion, that entity is called as hepatic hydrothorax. Liver disease responsible for pleural effusion. Then how is this happening? Whenever there is a liver disease, the ultimate result will be ascites, excess fluid within the abdomen. Normally your diaphragm will be having tiny holes which will not be open during equilibrium. Whenever there is excess pressure in the abdomen, these diaphragmatic pores will open. Once they open, from the abdominal cavity through the diaphragmatic pores, fluid can migrate into the pleural space. So the precise mechanism in hepatic hydrothorax is there is transfer of fluid via diaphragmatic pores into pleural space. The next reason for transudative pleural effusion is a procedure called as peritoneal dialysis. you must be knowing dialysis is of two types. If you use blood, it is hemo. If you put a catheter in the peritoneal cavity and you are infusing high concentrated fluid, it is peritoneal dialysis. Sometimes accidentally, if patient is infusing huge amounts of fluid, there will be increased pressure in the abdomen. Again, diaphragmatic pores will open and fluid will gain access into the pleural space from the abdomen. So the mechanism for hepatic hydrothorax and peritoneal dialysis are generally similar. And next important cause is hypothyroidism. Actually, why pleural effusion, how pleural effusion happens in hypothyroidism, the mechanism is unclear. But whenever pleural effusion happens in hypothyroidism, it is generally transudative in nature. So it is an unclear mechanism. But whenever pleural effusion happens, it is usually transudative in nature. So this is transudative effusion. Life is easy. You think whether it is heart disease, kidney disease, liver disease, etc. But if it is exudative pleural effusion, life becomes very, very hard and you have to evaluate for so many things. So what you need to do is, you should send the fluid for cytology. So why I should send it for cytology? To look for any possibility of malignancy. Then I should also send it for cell count to see what is the type of cell elevated. Then I may need to send it for gram staining. So why I should send the fluid for gram staining? To see any possibility of infective etiology. Most importantly, I should send exudative pleural effusion for TB markers. So what is the reason behind this? Because right now, most common cause of exudative pleural effusion, worldwide is tuberculosis. And what is the nature of this pleural effusion? In TB, it will be lymphocyte rich pleural effusion. So if you see the cells, it will be filled with lymphocytes. And what are the important markers? There will be elevated adenosine deaminase, also written as ADA, adenosine deaminase, elevated ADA. The cutoff value is 40 international units. Another important marker is interferon gamma. Interferon gamma, it will be 140 picograms per ml. So what is the significance of these markers? Whenever your body is actively fighting against TB, there will be some substances released. One such substance is ADA and other is interferon gamma. So if the ADA and interferon gamma are high in that fluid, it means your body is actively fighting with TB. The chances of TB pleural effusion is high. ADA more than 40 international units, interferon gamma more than 140 picograms per ml. Next, you should also know any possibility of low glucose pleural effusion. So when do you call it as low glucose pleural effusion? When pleural effusion glucose tends to be less than 60 mg%. So what are the low glucose pleural effusion that you come across? We have empyema, malignancy, and rheumatoid arthritis. So what is empyema? Empyema means pus. So what does pus contain? Pus contain lot of bacteria. And what do they consume as food? Glucose. In malignancy, there will be actively dividing tumor cells. And fuel for their metabolism is again glucose. In rheumatoid arthritis, just like arthritis, As a part of systemic involvement, there will be pleuritis. Because of pleural inflammation, as a reaction, there will be pleural effusion. And these inflamed pleural cells will have very high metabolism. And fuel for that metabolism is again glucose. Let it be empyema, malignancy or rheumatoid arthritis. As a part of pathophysiology, from the pleural space, actively glucose is consumed. So within the pleural fluid, glucose will be reduced. Then you should also have an idea regarding high amylase pleural effusion. So this is commonly seen in pancreatitis, in few malignancies, and also esophageal rupture. Now first let us see how pancreatitis is responsible for pleural effusion. Once again, your pancreas is a infradiaphragmatic structure. So whenever it is inflamed, it irritates the diaphragmatic pores, resulting in opening of diaphragmatic pores. Now through these diaphragmatic pores, pancreatic inflammatory fluid will come into the pleural space. What does pancreatic inflammatory fluid contain, students? Amylase. Then why in malignancy there can be high amylase pleural effusion? Few malignant cells, they themselves can secrete amylase. You must be knowing, malignant cells can produce whatever substance they want. Then in esophageal rupture, why there is pleural effusion? You know that esophagus is a mediastinal structure. Adjacent to the esophagus, there is a thin mediastinal pleura. Whenever there is a significant damage to esophagus resulting in its rupture, with that damage, the mediastinal pleura will also be damaged. So whenever mediastinal pleura is damaged, the esophageal contents will go into the pleural space. So what does esophagus contain, students? What does esophagus contain? Saliva. What does saliva contain? It contains amylase. Then after this, you should have an idea regarding high lipid pleural effusions. These are also called as white colored pleural effusions. So there are two entities in this. Number one is referred to as chylothorax. This is accumulation of chyle. This is accumulation of chyle due to thoracic duct rupture. Most common cause will be a surgical trauma. Most common cause will be surgical trauma. Disease defining feature will be pleural effusion triglycerides. Pleural effusion triglycerides more than 110 mg%. So observe here, you must be knowing in your body there is a mediastinal structure called as thoracic duct. Adjacent to the thoracic duct there is mediastinal pleura. Whenever there is a chest surgery, accidentally during this surgery, thoracic duct can be damaged. So whenever thoracic duct is damaged, the surrounding mediastinal pleura can also be damaged. So the contents of thoracic duct will start accumulating in the pleural space. What does thoracic duct contain? Chyle. And what does chyle contain? Triglycerides. So here the disease defining feature is pleural effusion triglycerides will be more than 110 mg%. Next what we have is pseudochylothorax. Next we have pseudochylothorax. So this pseudochylothorax, it is due to accumulation of cholesterol in chronic effusion. Accumulation of cholesterol crystals cholesterol crystals in chronic effusions. In chronic effusions such as TB, rheumatoid arthritis. So here the disease defining feature will be pleural effusion cholesterol. It will be more than 200 mg%. Now observe here, students, whenever there is a chronic disease such as tuberculosis or rheumatoid arthritis, now the pleural effusion must have been there for months together, and as a part of inflammation, so many cells must have come into the pleural space. So once there are many cells in the pleural space, as a part of their life cycle, at some point all these cells will die. Once these cells die, from their cells cholesterol will be released. So if somebody asks me, what is the source of cholesterol in pseudochylothorax? Your answer should be from the dead cells. Now if you observe here, students, these both are high lipid pleural effusions. Because of the lipid content, they will be white. So what is the lipid elevated in chylothorax? It is triglycerides. What is the lipid elevated in pseudochylothorax? It is cholesterol. So very important. Both these are lipid pleural effusions. So what is the lipid elevated in chylothorax? Triglycerides. Lipid elevated in pseudochylothorax? Cholesterol. Because of lipid content, they appear white. And last, in exudative pleural effusion, you should see, is there any drug related pleural effusion? So what are the drugs that can cause pleural effusion? So there is a big list. I'll just give you the relevant drugs that can be asked in your exam. So it can be caused by amiodarone. It can be caused by bromocriptine. Then dantrolene. It can be caused by methysergide, and also nitrofurantoin. So these are the various drugs responsible for pleural effusion. Amiodarone, amiodarone, bromocriptine, dantrolene, methysergide, nitrofurantoin. So whenever they give you any pleural fluid analysis, first with the help of Light's criteria, students, you must be able to know, are you dealing with transudative pleural effusion or exudative pleural effusion? Now if it is transudative, you have to look for any possibility of heart disease, kidney disease, liver disease, a procedure called peritoneal dialysis, or any thyroid disease. Whereas if at all it comes out to be exudate, life becomes very hard. So you have to look for any possibility of malignancy, infective etiology, TB etiology, any possibility of high amylase pleural effusion, any possibility of low glucose pleural effusion, any possibility of high lipid pleural effusion, any possibility of drug intake by the patient. So if you go through this algorithm, you will finally identify the etiology of the pleural effusion. Now once you effectively treat that etiology, the pleural effusion can also be managed appropriately. Apart from this, there are few important exudative pleural effusions asked routinely in your exam. Let us see what are they. So write down important exudative pleural effusion. Number 1, we have parapneumonic effusion. The textbook definition of paranpneumonic effusion will be effusions related to pneumonia, bronchiectasis, lung abscess. So whenever there is an infective manifestation in the lung and it is responsible for a pleural effusion, the broad term is called as paranpneumonic effusion. And what will be the usual clinical features? Patient will have fever, shortness of breath, chest pain. Whenever there is a paranpneumonic effusion, in majority if you treat the underlying infection, it might be sufficient. But there are few situations where you should immediately put an tube and completely remove the fluid. So what are those indications for active intervention? What is that active intervention? It is nothing but ICD, intercostal drainage. ICD, intercostal drainage. So in which situations you should immediately put a tube and completely remove the fluid? Number 1, it is pus in pleural space. Pus is a huge source of infection. It has to be immediately removed. Then presence of pleural effusion pH less than 7.2, pleural effusion glucose less than 60 mg%, and loculated pleural effusion. Loculated pleural effusion means within the fluid septa are formed. This can be known very well by ultrasound chest. If you find any one of the following, they indicate that there is some active inflammation due to active infection. Anywhere in the pleural space, if there is active infection, it has to be immediately removed. Why? What is the adjacent compartment to your pleura? It is mediastinum. If that infection migrates into mediastinum, sepsis will develop very, very rapidly. So any active infection in the pleura should be immediately removed. Then pleural effusion gram staining reveals plenty of organisms. It means again the fluid is actively infected. Any inactive infection should be immediately removed. Now I'll give you a clinical scenario. There was a 35-year-old male patient who came to my clinic and he was having features of fever, shortness of breath, chest pain. I have taken a chest X-ray. It was showing right-sided pneumonia and also pleural effusion. This combination, I thought it as paranpneumonic effusion, and I wanted to know the consistency of the fluid. So what I have done, I have put a needle and I have aspirated. So when I started to aspirate the fluid, this was the consistency of the fluid. Now what will be your diagnosis and what should be your next step in treatment, students? So this brownish colored fluid, it is called as pus. Pus in pleural space is referred to as empyema. Whenever there is pus, what should be immediately done? Intercostal drainage. If there is pus in the pleural space, immediately you have to put a tube and completely remove that pus. Diagnosis is empyema and next step in treatment will be intercostal drainage. Coming to another paranpneumonic effusion, another exudative pleural effusion important for your exam is malignant pleural effusion. This malignant pleural effusion, Either it can be due to primary tumors of pleura or as a part of metastasis. So generally metastasis will be the most common cause of malignant pleural effusion. So whenever there is a pleural effusion which is malignant, most probably it is due to metastasis from elsewhere. Now coming to the biggest problem in malignant pleural effusion is recurrence, very common. Even if you put a needle and aspirate today, within few days the fluid will accumulate. Then what will be your usual management? Generally, the initial step will be a therapeutic thoracentesis. Therapeutic thoracentesis in the sense you are going to remove about 1.5 liter of fluid. Now if the fluid is not reaccumulating, there ends the story. But in majority there will be recurrence. Now if there is recurrence, what is the traditional method? Traditional method is one has to insert an intercostal drain. Now say for example, this is the healthy lung. Around that you are having the pleural membrane. This is the diseased lung. Because of the disease there is development of malignant pleural effusion. So the initial step, as we have discussed, after therapeutic thoracentesis, if the fluid is recurring, I have put an intercostal drain. Now you observe for a while. Once fluid is drained, after few days the fluid will drain and lung expands. The lung is going to expand. After this, what we have to do? Again, let this be the healthy lung and this is the diseased lung. It has expanded. And let this be the pleural membrane, and inside there is an ICD. Now once the lung is expanded, fluid is drained. Now through this ICD we have to inject sclerosing agent. Sclerosing agent in the sense talc or doxycycline to obliterate pleural space. So what we do here is, through this ICD we inject this sclerosing agent. Now this sclerosing agent will go into the pleural space and it will function like an adhesive. It will function like a gum and it will adhere the pleural membranes together. Once the pleural membranes are adhered together, there will be no space for fluid to reaccumulate. So this method of fusion of pleural membranes is called as pleurodesis. Now one can get a valid doubt, sir, you are fusing the pleural membranes, will there be no problem in lung mechanics? Point to know here is, by the time a patient with malignant pleural effusion reaches you, he is already having advanced cancer, and moreover his life expectancy is only few months. In this last few months of his life, instead of asking him to come to your clinic daily, putting a needle and aspirating, this pleurodesis can be a temporary palliative measure. Initially there will be some problem with lung mechanics, but eventually body will adjust. Now what are the practical problems with this method? First of all, the ICD you put is a big tube, and especially in pain sensitive patients, as long as the ICD is inside, they will be complaining of pain. And moreover, not all patients fluid will come out in 2 or 3 days. Some patients it may also take 1 or 2 weeks. And as long as the tube is in the pleural cavity, apart from pain, if it is for longer duration, as it is a bigger tube, the infections from outside environment can also again access into pleural space. Now to overcome these problems, and also based on patient's preference, nowadays we are putting a smaller tube, and this is referred to as indwelling, made up of special silicone material, indwelling pleural catheter, also called as Ple323 catheter. Ple323 catheter. So you can see this is a small flexible tube, and the method of putting is slightly different from the routine ICD. So we try to go in subcutaneous plane also, so that the tube will not get expelled that easily. And this has shown that patient will have less pain, less chances of infection. It will also permit frequent drainage of fluid, and overall this was well tolerated by majority of the patients. So this was well tolerated by majority of the patients. So if somebody asks you what is the traditional method of management of malignant pleural effusion, your answer should be ICD pleurodesis. What is the recent method? It is indwelling pleural catheter, also called as Ple323 catheter. Now let us see a question regarding this topic. There was a 60-year-old male with history of alcohol abuse. He is evaluated because of insidious onset of dyspnea over a course of 6 weeks. He is having a moderate right-sided pleural effusion. Serum amylase is only 20. Normal value is usually within that range only. Glucose is also okay in the blood, but they have given pleural fluid analysis. If you notice here, the LDH ratio is less, protein ratio is less. So whenever they give you any pleural fluid analysis, first see the ratio. By seeing the ratio, this is looking like transudative pleural effusion, because protein ratio, LDH ratio is less. Because it is transudate, I can rule out this chronic pancreatitis and lung cancer. But patient's albumin is less, prolonged prothrombin time, normal urine analysis, ECG is also normal. What is the most likely diagnosis? Now this is a transudative pleural effusion. Out of this, heart failure is also causing transudative pleural effusion commonly, but no particular history of heart disease, and ECG is normal. So with that, I cannot conclude that patient is having a heart disease. Whether patient is having any liver disease, his habits, alcohol abuse, because liver is responsible for production of albumin, liver is not working in this patient, albumin is less. And it is also responsible for proper clotting, because liver is not working, clotting is also not happening properly. So there is liver disease and transudative pleural effusion. Combination of liver disease and transudative pleural effusion, it is hepatic hydrothorax. So when they give you any question on pleural effusion, first by Light's criteria, know whether it is transudate or exudate. If it is transudate, generally look for systemic causes. Here I could get a systemic cause called as liver disease, and there is transudative pleural effusion. This combination is called as hepatic hydrothorax. Next, coming to NEET 2022 question. See, sometimes examiners will not only ask you memory based questions, but also common sense. So this is a common sense based question, not memory based question. Which of the following is not cause of pleural effusion? Drug not cause of. We already know that amiodarone, bromocriptine, dantrolene causes. Even if you don't know that these three drugs causes pleural effusion, this is a very common drug, metformin. If really metformin was causing pleural effusions, by now that information must have been in your WhatsApp. So this is a very common drug and we are not seeing any pleural effusions. Actually methotrexate causes pleural effusion, not metformin, students. So sometimes in exam, questions will not only be based on memory but also based on common sense.